feel so well.
Okay.
Okay, so the stomach is here. This is the duodenum.
Yeah.
So there's a tumor here. So this space you can't even go through. How big is the scope? The scope thickness is about maybe this pencil. This pen.
Okay.
So if it can't even go through, you imagine the food that you eat probably can't go through. And the stomach, right, does not do any digestion in per se. What the stomach does is a capacitance organ. It doesn't change the food that you eat into liquid. The part that changes it to liquid that moves distally is the small intestine. So it means to say any residue that you eat at this stage, if it doesn't go through, you'll just get blocked. And it's almost inevitable looking at this situation that you will definitely block at some point.
At some point.
And even if it doesn't block now. So the question is which point? We don't know, but if you think about the food particles, right?
Fair enough.
Are they bigger than this pen? Most likely they are.
No, fair enough what you're saying.
Yes.
But if that's the case, wouldn't it just be better to just try to take out the lumps?
No. So the only way to take out the lump is by surgery.
Right.
So the lump is not a tumor it's not a small lump originating from the small intestine. It's not like a growth here. From what it looks like, it's actually a gallbladder. It looks like a gallbladder tumor that's pressing down into this. So to bore something inside is not recommended. The only way to do it is to remove this entire part.
That is, according to your
surgery.
junior, a very serious surgery.
Yes.
How serious? As in, can you do it tomorrow?
No. This surgery. Okay, so how should I put this to you? So this is what it looks like is a non-conventional cancer.
Oh, right.
So conventional cancers are like that. If a cancer happens in the stomach, we remove the stomach when it's no spread, and that makes sense. And that has proven survival. Non-conventional cancers are like cancers that are locally advanced. Locally advanced cancers need to go through a few things for us to know of its benefit to you. So conventional cancers, let's say gastric cancers, we remove part of the stomach. We know there's a certain percentage of survival that we can achieve for you. Then that time the benefits outweigh the risk. Non-conventional cancers like locally advanced cancers means cancers that has invaded other territories. So this looks like either a gallbladder cancer that's gone inside the duodenum or a duodenal cancer that's gone inside the gallbladder, of which both are unusual. When these kind of things happen, the reality is that it's usually more advanced than standard cancer, and that the potential of spread elsewhere is always much higher. So the few things that we needed to do, the CT scan to check that there's no spread to the lungs, alright, and there's no spread to the rest of the organs. This determines the so-called this determines the impact of the curative surgery for this. That means if there's no spread, we are more likely to be able to give you a reasonable long-term survival after the operation.
When you say long-term, what are you talking about?
Okay, so just to tell you the statistics. So let's say this is locally advanced gallbladder cancer. If it's gallbladder cancer, usually the survival is not that good. Usually it's about 5 years, about 30%.
Yeah, that's what you told me before.
Yes, that's right.
But you're very convinced that this is cancer.
Most likely.
No. I mean,
which is why
you didn't even do a biopsy.
No, we did a biopsy.
No, at that time when you said to me that I had sort of like 30% survival rate, for 5 years or
those
whatever.
are the possibilities.
Yes, right. So the point I'm trying to say is that shouldn't we first check that it is cancer before you say, you label it as a cancer?
No, I did not label it as a cancer. What I told you is that's a possibility, and that we needed to do so at that time it's a possibility. When I do the scope, it is most likely, because we already seen a mass that's unusual.
Oh, I see.
So at this point it's most likely. At this point we say it's a possibility.
So now you've done the endoscopy, and you are convinced without the biopsy that this is a cancer.
We took a biopsy. So usually how cancers look like is that when we do a scope, right, and when there's contact bleeding, it's abnormal cells. So if it's an ulcer, it doesn't look like this most of the time, and it's not obstructing lumen. So based on exclusion, a lot of times where there's a big mass obstructing and contact bleeding, and it looks like this, most of the time it is.
So this bleeding here was after you've taken the
No,
biopsy.
even touching it, it bled
It bled.
because we needed to go through. So
Oh, you push quite hard then.
no, when
No.
you rub on an abnormal tissue, you always bleed. But there was more bleeding after we did the biopsy. That one is for sure.
Okay, for sure.
Yeah,
Okay.
for sure.
Yeah.
Okay, so we need the final results for it to be confirmed about the cell type
Right.
or whether it is cancer. So that we need some form of certainty. Number two is functionally what are you going to experience? So having blockage here is inevitable. The question is when, and it would be risky for you if we said that you can continue to eat, that something blocks inside, because what will happen is that if there might be complete obstruction just from the next meal. That's the reality. When it's complete obstruction, no saliva goes through. Your stomach creates about 1.5 liters a day. Without distension and reabsorption, what will happen is that you'll vomit.
Right.
And the vomiting depends on the circumstance of it. Sometimes it is uncontrolled vomiting. You might go inside your lungs, which is not
Yeah,
so
I
good.
know. I got that one.
Yeah, so that's the danger of that. What you will need at this point, the best thing for you to have is still nutrition. But the nutrition will have to go through this. That means through the stomach, through the blockage.
So you still want me to do the tube through the nose?
That will be the best nutrition.
That is the best.
There are
So
two routes of nutrition. One route is through the intravenous. The other route is through your enteral or your lumens or your gut lumen.
okay.
If you are able to feed through your gut lumen, that's always proven to be better than parenteral nutrition.
Okay.
So that is also contingent on what's the size of the lumen. If there's still a lumen, the best thing is to wait while there's a lumen, try to put a tube immediately through it so that you can feed. The worst thing that can happen is that there's no lumen. If there's no lumen, you just need a nose tube. We might not even be able to give you food through the nutrition. You have to go through intravenous nutrition. And the only way to give you nutrition subsequently might be a surgery to do a bypass.
Oh, a
That means,
bypass.
yes, to bring small intestine proximal or before the blockage so that the whatever you eat can go through. But that would be
I mean, I would think that, the best thing to do is to just take it out altogether.
yes. So, but to do this,
Yes.
we need to be confirmed or 100% certain that it's a cancer, 100% certain that it's cancer that hasn't spread yet. Because if the cancer has spread, let's just start with that. If the cancer has spread, massive surgery that is risky to you will not give you survival benefit.
I see.
Yes.
But then at the same time, it means that my quality of life is going to be affected because I won't be able to eat except through the tube anymore.
Correct. So if that happens,
I'd rather not.
yes. So which means to say, if there is no role for curative surgery, then we can still improve your quality of life by giving you a bypass surgery, which will ultimately be much less risky than a curative surgery.
But a bypass surgery means still a nose tube.
No, after the bypass surgery, the nose tube can come out.
And then you can eat normally.
Yes.
Okay. So why not do the bypass surgery and forget about all the other things then?
We can do that if you feel that you personally do not want to pursue cure. If you do not want to pursue cure, then we respect your wishes, we do the rest.
Oh, I see.
Yes,
Okay,
yes.
that's fair enough.
Yeah.
And so the bypass surgery is a minor surgery?
More minor than this, there are still is risk.
Okay, so
Usually the chance of leakage is about 5% or less. Bleeding, infection, all these add together probably in total less than 10% chance of major complications.
and then so going back to the fact that we do the biopsy, we do the CT scan, the results of which you will be able to say for certain whether we could go ahead with that means that if assuming everything else is clear, we can go ahead with that. Then after that surgery, what happens next?
Okay, so this surgery is complex. We'll have to discuss it. But looking at this, it might involve some part of the liver, the entire gallbladder, the entire biliary system, the bile duct system, it might involve the pancreas as well, because this area is intricately linked with the first part of the pancreas. So it might involve liver, bile duct, duodenum, first half of the pancreas.
But the MRI scan did not see any, funny bits from on the liver or anything like that, did it?
Yes, it did. Yeah.
It did.
Yes. So in this segment of the liver, segment 5 of the liver, some part of the gallbladder, and when it goes into the duodenum, that means it has the normal structure of your body is like this. This is the normal structure of your body.
Yeah, you've given me that picture.
So the normal structure of the body is like that. But right now, this and this is inseparable, which means the tumor is at least involving this part already.
Already, yeah, okay. But that doesn't mean that it involves the part behind it.
No, okay. So behind it, there's the liver mass.
There is a
segment
mass
5,
also.
and probably
How do they see that?
Probably also segment 5 of the liver.
Okay, I see.
Yeah.
So that will all have
Yeah.
to be taken out then, basically.
Okay, this is where the tumor margins are. That means when we want to operate, we need to take more than that.
Okay,
So the area needs to be more than that
yeah.
to ensure that there's no tumor left behind. And when it's more than that, sometimes it involves like this. So there needs to be a margin. We need to make sure that there's no tumor left over.
And then if we have to organize this, say for example, how many days we've got left? Have you managed to get a CT scan for me today?
The CT won't be on Sunday. Yeah, you won't.
No.
Yeah, it wouldn't be.
So definitely, or is it definite tomorrow?
We don't know, but we need to ask them. Yeah.
Yeah, but
But
then,
it should be earlier than Tuesday, if we can.
yeah,
You already have a slot on Tuesday, but
Correct.
what will happen tomorrow is that we'll get the doctors who do the scope for you to see you, and then try to put the tube in for you.
right.
Yeah.
And then after that, what happens? How long before this procedure?
There are a few necessary points that we have to wait. So the necessary points to wait is the biopsy, because the biopsy results
Takes a week, right?
needs to have a dye test, and that dye for you to see the cells needs some time, and that is the definitive scan. Then the CT scan, when done within the next week, should be able to tell us whether there's any suspicion of tumor elsewhere. If there's, hopefully there's none, but if there's any suspicion that the tumor has spread beyond confines, you might need a PET scan, which typically takes some more time.
Yeah.
Yeah, but all this is done to ensure that you do not undergo unnecessary surgery. Unnecessary surgery means non-curative surgery. Because if you want to undergo a surgery that is risky, we must be absolutely certain of its benefit for you. Otherwise, it's not worth it for you.
All right. So what happens if I said no? I don't want to go through this surgery.
Then then doing all the rest of the investigations will not be so meaningful for you.
That's right.
Yeah.
Agree.
Yes.
So in that case, if you just do the bypass so that I can have my quality of life back,
Yes.
How long will that take?
Okay. So before we do the bypass, I still need to be certain that it's cancer, lah.
Yeah. You just told me that
No,
it was.
most likely, but we need the 100% cell type. So there needs to be conclusive cellular evidence that it is 100%
Okay.
cancer.
It's not going to be long, isn't it?
No.
Because you did it on Saturday.
Yeah,
so
but
assuming next Saturday,
it should be within this week.
within this week,
Yeah.
this coming week.
Yeah.
So within this coming week, that happens, then, and we agree that let's do the bypass. Then, how long will that take?
We can arrange for the bypass on an emergent basis. So
Immediately.
Yeah, we can do it in the emergency theatre. So, but that one is subject to queue, which means to say that if a patient comes in with a head injury or
Of course.
heart attack, those take precedence. But we can do it for you whenever. Which means I'll put it on the queue. If you want a bypass surgery without cure,
Yeah.
that one can happen almost any time of the day.
And then, when will I recover?
Usually, if there are no complications within a week.
Oh, okay,
Yeah.
that's good. So, why didn't you schedule that then?
We can only
In the-
schedule when the tumor is confirmed. Yeah, when it's
You mean you
confirmed
can't
cancer.
schedule it as a potential?
No,
Can't.
no.
You see? All right. Because the reason why I'm asking is I'm leaving Singapore on the 22nd of April,
Okay.
and that is my main concern,
Okay.
and I don't want to delay it.
Okay.
So everything has to be done before that day,
Okay.
including the recovery period. Yes?
Well, there will be risk of complications, and if the complication happens, then we can't be certain when you'll be, medically fit to travel. That's the part that we can't guarantee. But what I can tell you is the complication percentage risk.
Yeah.
Yeah.
But if you do everything earlier to the point where, in March everything is finished, then 22nd April is
Yeah,
3 weeks into it,
Yeah.
and that
So
should be
potentially,
fine.
yeah, potentially by all norms, yes.
Yeah, and then I'll need, of course, all the reports and everything else so that I can take it back to the UK and hand it to my doctors over there.
Sure. Yeah.
Can do?
Can. So those scan reports we can give you, the cytology results you can have it, and then we can do the bypass for you. Yeah. You can actually travel with the nose tube so if you really want to go back quite early, you can do without the bypass and go back with the nose tube, which will even be earlier, because you can still be fed through the nose tube and you will still not have functional obstruction. And more importantly, if you are seeking curative treatment in the UK, then there will be no disturbance to the surgical field, which means to say that it will not be scarring
It'll still
inside.
be intact,
Yes, that's right.
and then they can do it if they
Yes.
want.
Yes, that's right.
No, I don't want that, because if UK, knowing the NHS, it take months to schedule something like that. Months.
Yeah, right.
So I'm not going to risk that. I'd rather you do that bypass thing here, and then let me go back and live a normal life till I die. That's it.
Okay, what's your expectation of
Death?
yeah, as in that's what actually I'm asking.
Yes, I was given
Sorry.
a fortune teller when I was 20 told me that I would die when I'm 64. So I kind of expected it until I'm 65. So I think he's kind of right, and therefore, I don't have much expectations. Obviously, I mean, I don't want to. I don't know. I don't want to live till 80. Let's put it this way.
Okay.
I don't want to live till even 70s. It's a bit old. But yeah. So I'm quite happy to just go.
Okay, I understand.
So if tonight I die, that's it. It's not a big deal.
Okay.
Right? So don't have to prolong my life unnecessary to make. I hate pain. I hate anything to do with making things difficult, So I want to live my life normally up to the very end. And if I'm in pain, give me all the morphine you can, top the dose up. I don't care, but I just want to live peacefully.
So
and go peacefully.
Yes. So there are a couple of challenges to that. So
Yes.
when the tumor is intraluminal, the chance of bleeding is significant. That means it might bleed on its own. Alright.
Well, you just bled it yesterday.
No, it's different. So the biopsy bleed should stop. What it means that the tumor will ulcerate and it will cause bleeding by itself. And that is.
If you don't take it out.
Yes, that happens as a natural consequence of it. There's another structure that travels near there called a bile duct. And it is inevitable the tumor may invade and block it in the future. So in the future, there's a potential that your eyes might turn yellow and your liver will be affected by that. And the treatment of that sometimes might have to be another bypass to the bile duct.
Two bypasses.
Might be another bypass to the bile duct, because there's no reasonable way that they can reach it through a scope already at that time. So which means to say that those two things are the things that might happen in future, but we can't suggest that we treat it now because it's not causing any functional problems at this moment. The only way of preventing that in the short term is to remove all the tumors.
So the result will come
So,
out.
yeah, but then
So while I hope that we do not have any complications from that, and that bypass will solve the problem of the risk of not being able to eat at this moment, those other problems are things that we know from experience that will happen to most of the patients who have in situ tumors. So the bleeding sometimes can be stopped with external radiation therapy. The biliary obstruction, usually you can't change. Usually you need a scope to go through and stand the product. That's what happens, that's the requirement. But in your case, the excess of it might be blocked completely from
okay.
yeah, so that's a possibility.
I mean, I just think, what about some keyhole surgery where you just take out the gallbladder?
No. So keyhole surgery for the gallbladder is for gallbladder stones that have no tumor obstruction. So we do keyhole surgery even for major surgery. Whether it's keyhole or open, it depends on the area of resection. For yours, the area of resection is large, and the surgery to cure it would unfortunately be to remove all the organs around. So let's say there's a tumor here invading. If we take out half the tumor, is it effective and helpful? No, it's not. It's not meaningful because the raw area will bleed and the tumor will still grow almost immediately. So that's no point. So even if we remove the gallbladder, against all norms, it will still not prevent your eyes from becoming yellow because the tumor eventually will cause the bile duct obstruction. So that's what you might be facing in the future. So while I hope I have to be upfront and tell you all the natural history. So while I hope that the bypass would solve the problem of how you of your problem of eating, the bypass will not solve the problem of the tumor bleed, and it will not solve the problem of bile duct obstruction, which are both very likely events to happen in the future. Yeah, so this is something that I have to tell you.
So if let's say you do the bypass and then later on I decided, oh, I want a new lease of life, then can you still do the other part?
We will need to check that it has not spread because there might be a time that's
Time sensitive.
yes, and that the tumor cells might spread. So
How
fast we don't know. We don't know the doubling time because conceptually, if you want to talk about concepts, the concepts is that once you have tumor, you might have tumor cells inside the bloodstream already. So that in norms are considered metastases, but that in terms of treatment is not considered metastases. In terms of clinical practice, not considered because it is not a clinical standard to check for isolated tumor cells in the blood. Isolated tumor cells also do not necessarily become metastatic cancer from the start. So basically on the scan, what we are looking out for is growths that are bigger than 1 cm elsewhere. In the absence of that, we assume that the cancer cells have not spread at that point in time. But are there exceptions? There are exceptions. But these are clinical standards throughout the world that we follow. So short of that, we can't invent or suggest any other alternative method to the standard treatment at this moment. So which means to say, let's say at this time point we do a scan for you, we check everything and there's no spread, we accept that there's no spread and we can do the surgery for you. Then there might still be a chance of you developing metastases some months down the road, which is too early.
Yeah, you just don't know.
Yeah, we just don't know. But if we did 100 patients with no spread with these problems, we can give you, out of these 100 patients, maybe 30 will be alive at the end of 5 years. So that's the only statistics that we can sort of that's proven by facts to tell you.
Okay.
Yeah.
What if okay, let's go back to the step whereby you say, okay, remove all the bits where the cancer has already invaded. Now if you do that, then what is my quality of life?
Okay, so it depends on the extent of the operation. So if your surgery involves liver, gallbladder, bile ducts, your chance of death within 90 days from the surgery is about 3 to 4%.
Okay.
The chance of complications is about 20 to 30%.
Okay.
your quality of life should still be normal. You should still be able to eat through your mouth, pass motion through your backside with no drains inside your body. You might have what we call a complication of the surgery in the long run as reflux cholangitis, because your bile duct is not abnormally joined to your small intestine, and that is a limitation. Sometimes the bacteria from the intestine can travel inside the bile duct. So that's an underlying risk that we have to accept or live with. If the surgery involves the pancreas and the liver, your chance of death in 90 days becomes 10%. 10%. Your chance of complication almost doubles to 30 to 40%. Without any complications, your life should still be largely normal, and the risk of 10% diabetes with the removal of the head of the pancreas. That's the long-term effect. But in the short term, your chance of bleeding will definitely be higher.
So you said again about the diabetes? I didn't
So
catch
because the pancreas head is removed, there's a 10% chance that you might be diabetic.
I am diabetic
and
already.
dependent on injections.
Oh,
So it
insulin.
might be, if you have diabetes, it might be worsening. And
Because of that.
so that's the long-term risk. But the short-term risk, the chance of death is almost double within 90 days, and the risk of complication is almost double within 90 days.
I see.
That's due to the nature of the pancreas structure. So the pancreas, the majority of the time, it actually leaks when it's very soft, because it's almost like tofu. You put two structures together, although you make everything look perfect, whether the tofu or the pancreas, soft pancreas, will heal or not is largely dependent on it. So there's a good 20-30% of the time it wouldn't heal. When the pancreas doesn't heal, it causes leakage of the pancreatic enzymes to the surroundings, and when it goes to the surroundings, it causes breakdown of all the structures around, including blood vessels. And the blood vessels sometimes bleed and cause life-threatening situations. So that's where the main complication comes from. So if you were to opt for that, then that's what might happen. That's the risks, but the aim is to so-called eliminate the local complication risk for as long as possible. The chance of recurrence of this tumor looks like 60-70%, right? Because your chance of death within 5 years, or your chance of survival within 5 years, is about 30%. Let's say it's gallbladder cancer. Let's just say it's gallbladder cancer.
You don't even know what cancer it is right now.
Yeah, we don't know. We don't know. I told you my suspicion. It can be gallbladder inside the duodenum, or duodenum onto gallbladder. But either way, it's still considered to be locally advanced because it goes beyond the norms. At this point, we are not even certain whether it invades blood vessels. If it invades blood vessels, we have to cut it and rejoin it. So that increases the complexity of the operation. So all these, the standard operations like the colon operation, even if you remove half the colon, all this always sounds more serious, but actually the complexity is not that high and the risk is not that high. But when it comes to so-called tissue pains, traversing and surgery of the hepatobiliary system, the complications rates and the survival are actually not that high and not that good. But unfortunately, despite many years of research and clinical practice, that remains the limit of the kind of treatment that we can give.
I see.
Internationally. Yeah.
Right. So I guess we'll have to wait and see then.
Yes, unfortunately, we have to.
And you
see.
have to.
The necessary time for the biopsy to be confirmed.
Yeah.
And the necessary time for the scan to be done and shown.
But the scan can be done, you said, by tomorrow.
Usually by tomorrow or Tuesday. Because right now we are converting a scan that's arranged for you in the outpatient setting to inpatient setting. And I don't control the scans. The scans are controlled by the radiology department.
Yeah, but if there's an urgency, they might, they have to. You told me that if you admit me,
Yes.
you would get the scan.
Usually in a couple of days.
Expedited.
Yes.
But it hasn't actually happened, and I'm just thinking, why do you keep asking me to be admitted? Since Thursday you've asked me to be admitted.
Because we can't be certain when you eat what will happen. I'm medically bound to tell you what is safe and not. So for example, so I can't force you to decide on any form of treatment. My job is to help you and assist you for the treatment.
Right.
So we know that there's likely to be gastric outlet obstruction, which is why I wanted to admit you earlier. When I did the scope for you and the lumen is like that, we are almost certain that it will block lah. And that to tell you that it's okay to continue eating would also be illegal for me lah.
Irresponsible.
Yeah, irresponsible for me.
Okay.
So and when there's a lumen like that, the chance for putting in the tube is the window is there. If we so-called find out that we can't do the tube, then a bypass or a peripheral nutrition is in order already. So obviously, if you ask me, would I hope for you to have all these things done immediately at the point that you're admitted? Yes, I do hope for you to, but I don't control most of the things except those indications that we can. The rest of it is subject to the system. Then your question would be, if it's really urgent, will it be done immediately? The answer is, the only time when it's really urgent is when the patient is almost on the brink of death from a serious incident. That time we ignore all norms, we push the patient down to the operating theatre, we don't even tell the anesthetist, yes, we do it immediately. That time we are allowed, we are honor bound, we are legally required. So that time, yes. But all the other times, we have to follow some set of rules and and requirements from other departments that contribute to the care. So, yeah. So, are there situations where you can get everything done immediately? Yes, there are. The situations is in private hospital where you can get the scan immediately, where resources far exceed what the baseline hospital needs are. So yes, those situations are, but yeah, we are not in that situation.
No.
Yeah, the public hospital is like that. I've worked in NHS before. While I can say we are so-called faster than NHS, I say we are definitely slower than
well, I'm glad I'm in Singapore to have all these things done, because in NHS I still be wondering what's going on. So the thing is, the question now is, if I have a block, where is it likely the pain to be? This side or this side?
This side, on the right side.
Right side.
Yeah, on the right
So at the moment, there's no pain at all. Twinges on the left once in a while, but I don't know why. Twinges. What do you think?
From the scan, it doesn't look anything obvious, but there's an MRI scan. It doesn't detect peritoneal metastasis that likely, and most of the time, touch wood, most of the time, even if they are spread, you might not have any symptoms. So the symptoms or how you feel might not be indicative of where the problem is.
Okay.
Yeah. So the scan is to exclude from image perspective that there is nothing. So maybe I just need to throw another spanner into the understanding. So there are 10% of patients with what we call miliary spread, like little bit of spread around the peritoneum that we cannot see on the scan. So there are 10% of patients that we think are operable when we go inside the abdomen, that look to, and we confirm with the frozen section that's already spread. In those kind of situations, we do not operate for you, because when there is spread, there's no survival benefit, no durable survival benefit long term from massive surgery. So in those kind of situations, we also don't.
So you just cover me up.
We will close you back, and then we'll do a bypass for you. Let's say you are going for the corollary surgery. So that's
At the same time that you just do the bypass.
Yes.
Okay. So as long as we agree that within a week you get all the results,
Yes.
and then we're talking about, today is the 25th already. So by the 2nd of March, you would know for sure, and then from there we proceed as to the next step. That's fine.
Yes. So I'm one of the consultants in the team. So within the team, there are other consultants, and we manage you as a team. So it might be me doing the surgery for you, it might be my colleague doing the surgery for you. But your aims of your care are decided by our discussion here and documented. So we will definitely still try to get your scans done, hopefully tomorrow, your scope done, the nasal, gastric and nasogenital placed, your biopsy results out within this week, hopefully. And we'll be able to have clarity on that. Then we can make a decision at that point once all these things the reports are out, what you would like.
Okay, so by tomorrow, right, after you've done the scan, let's say assuming you can do the scan tomorrow, and the other thing was the nose tube
Okay,
in.
the nose tube is independent of the scan.
Okay, if you do the nose tube in, I can go home.
Yes.
after the scan.
Yes.
So you sure about that? Then you discharge me the moment
Okay.
you get
Can.
that done.
Yeah.
All right?
Yeah.
So that I can go home and then feed through the nose tube. Is
Yes.
it?
Yes. Okay. So the nose tube, the dietitian needs to come up with the feeding requirements and the duration. So you need some learning. The new nose tube, if you are able to put it in, there are two ports. One port is to the stomach, the other port is to the small intestine. You feed through the small intestine and you take out fluid through the stomach tube.
I see.
It's a double lumen. So it's a double lumen. So one tube goes inside your nose, but inside it splits. One earlier into your stomach and one going into your small intestine.
Right.
Yeah. Yeah.
Okay.
Yeah.
And I need a blender, I suppose.
You won't be food. You'll be completely on milk.
Oh, I see.
Completely on milk. There will be
Nothing,
no
no
solid
food,
yes.
no solids. So what's the point? I love my food. Okay. So no
I-
point then.
You can't taste your food with a blender. I mean, okay. So if you ask me, technically you can have taste. You can chew it and you can spit it out.
Oh,
Yeah, but you will not have the satisfaction of being full in your stomach. So you can taste it, but you can't swallow it because it will not go through.
okay. Right. Fine. So that is the tube, and then but I can go home. That's the main thing.
Yeah.
Right?
Yeah. Don't leave your
That's-
husband alone. I understand. Yes.
Okay. Thank you. Thank you for all that.
Yeah. I'm
Appreciate it.
I'm sorry that it's a
Don't be.
not a nice problem.
Don't be. It's just part of life. It's not your fault.
Okay.
Thank you.
Okay.